Fifi for the kind introductions. I'm not entirely an expert, but here I'm like to give a bit of talks about the rib fractures and probably my 1 year experience in the trauma center in the southern HSAJB. So the covers of contents for my slide. So rib fractures actually cause a significant health burden in terms of morbidity and mortality. In the evolutions of regional anesthesia, I think it had slowly reducing the morbidity, mainly also mortality, in the elderly patients. But I think trauma is more common if it's in younger groups. But if we encounter the trauma in the elderly patient, they usually more frail and have more multi-body trauma components. So 30% of them actually develop respiratory complications. And one of the reasons why is because of ineffective pain management. So rib fractures can actually associated with pneumothorax, hemothorax, and lung contusion as well. So most of them will have mild to moderate respiratory compromise. So in order to prevent them to develop into pneumonia and atelectasis, we might need to institute the pain management as early as possible. So what we are more worried is when there's elderlies with more than 65 years old, multiple comorbidities, with multiple rib fractures. If the pain management is inefficient, this will definitely complicate it into mechanical ventilation and mortality rate is very high. Therefore, it is extremely crucial in early pain management control of patients with rib fractures. So the cornerstone is effective multimodal analgesia. So some of the scoring system has been developed in Western country. This is actually for easier stratification how you institute the analgesic ladder in a patient with multiple rib fractures. For this example, this is a study of evaluating the impacts of prognostic model for management of bronch chest wall trauma patient. So you can see the points are going into the age, reduction in SpO2, individual fractures, even in 2 fractures in 1 rib will get double score of 6. Patient with anticoagulant and antiplatelet mainly in the elderly, and also chronic lung disease. So divided into mild, moderate, and severe score. So going into the trauma tools, so it actually guides us when we have to treat it more aggressively. But in this content, when you actually already provide the trauma analgesic bundle, you should actually still consider regional anesthesia in all stages. So usually the trauma team will start the multimodal anesthesia and call us up for opioids or regional anesthesia strategy. So who are likely to benefit from regional anesthesia? Those who have moderate to severe pain or coughing, even on top of trauma analgesic bundle, who are unable to do a deep breathing exercise, incentive spirometry, and physiotherapy, mobilization as well. So the other kinds of rib fracture score is also quite identical. The pain strategy, I think, doesn't much difference, and I want to emphasize is consider regional anesthesia at any stage if the pain are not controlled with the conventional anesthesia. So what is the choice for rib fractures? I think there are multiple choice, but we had pretty little evidence because nowadays we shifting towards more interfascial plain block, but with the evidence of what is the mechanism of action of those, we hardly understood well. So this is the paper published by Ho and Kamaka et al. It's regional anesthesia techniques for a patient with traumatic rib fracture. You can see that there is multiple choice for you to perform, actually to reduce the pain. I think from many years ago, epidural blocks has been the gold standard and quite predictive effects of pain relief if you're going to reduce the pain in rib fractures. But judging from difficulties to perform in a thoracic level, also all the complications like epidural hematomas in case of patient with anticoagulants, and also hemodynamically instability in trauma patient, we have moved towards laterally, maybe to a paravertebral block or thoracic paraspinal interfascial block. One of the most debating one will be the electrospinal plane block. So the sagittal view of different kinds of block which we can perform in the rib fractures, that you can see that in the retrospinal plane block is much more superficial compared to a paravertebral and mid-transverse process to purer block. And there is a safety margin that we can use, which is the transverse process. So how do you choose? Mainly, I will recommend that we have to see what types of rib fractures, which can be anterior, lateral, even posterior. Patient factors, in terms of patient who had antithrombotic, patient who cannot actually mobilize, we cannot turn. Then operator factors means that how your familiarity and also you are trained to perform the regional anesthesia in rib fracture patients. So in this flow of management in one of the management of rib fractures, so Serratus anterior plane block are mainly more suitable for those patients who cannot stay still or in a probably respiratory depression, and their fractures are mainly in the anterior and lateral. But I think if epidural, paravertebral, and ESP can still work to reduce the pain for anterior and lateral fractures, if let's say the patient can be positioned. But in case of posterior and lateral fractures, I think we might need to think of electrospinal block or paravertebral block. So bilateral fractures, probably one injection of thoracic epidural is a good choice, but judging from the difficulties in the patient who are trauma, you're hardly able to position optimize in this patient, so you might be difficult to get a successful epidural in. So you might think of a bilateral paraspinal plane block. So comparison for all these regional technique. So if you can see that we have quite a high evidence of epidural and paravertebral block, and they stated that there's a 10 to 30% of failure rate in this patient. They are always have a drop in BP in epidural because you definitely will block the sympathetic blockade. 2% of them in paravertebral block, but very rarely you will see in interfascial block in the paraspinal. So, but we would not know how is the success rate and the failure rate. But I will give a bit of experience of me later on that I performed ESP in my center last time. So many choices, but in a European country, they actually putting in these 4 common performed regional anesthesia technique. One of it is thoracic epidural. I am not going to talk about it today. The more common one will be Serratus anterior plane block, erector spinal block, and thoracic paravertebral. All the technique will be teaching later, but I think we don't have paravertebral block. For Serratus anterior plane block, our target aim is to deposit the local anesthetic agent in between. There's 2 options: either the superficial serratus anterior plane in between the latissimus dorsi and serratus anterior muscle, or the deeper option in between the serratus anterior or intercostal muscle and ribs. So in the option 2 is more suitable for if you're planning for a catheter insertion and for continuous infusion or intermittent boluses later. So for electrospinal plane, your target will be the fascia deeper to the electrospinal muscle, which is on the transverse process. This is the picture showing the LA deposition in the electrospinal plane. So for thoracic paravertebral, your aim is actually to deposit the local anesthetic agents inside the small triangle boundary by the superior costal transverse ligament, the pleura, and the transverse process, as shown in the pictures. But this carry a risk of pleural injections if you're not careful. So a lot of debates, I think, is quite hot this day. Is that you want to choose a paravertebral or ESP? So mechanism of action, which published by KJ Chin, actually demonstrates some of the cadaveric and images spread of ESP, but to date, we still not 100% known why ESP is only tackle the sensory or pain block, but non other kinds of like temperatures and also motor blockage. So why I emphasize in antithrombotic drugs, because in the cases of why I choose ESP over PVV is they are more superficial block, and you wouldn't really worry that if the patient is coagulopathy or on antithrombotic as compared to paravertebral block. Okay. So some of the RCT actually shows that by doing the regional anesthetic technique, we actually reduce the opioid consumption. Hence, we reduce side effects of opioid like nausea, vomiting, somnolence, and pulmonary complication. So in a way, RA in rib fractures, we actually promoting them to be more active in doing the respiratory physio so that they reduce the respiratory complications, which the opioids doesn't serve the purpose. Other than that, actually, we can see that the intercostal plane block can provide a better pain relief after initial placement and less hypotension compared to an epidural block or paravertebral block. So I'm going to share a bit of my personal experience back then. This is judging because we are very tight in ICU bed to ventilate so many kinds of patients in HSAJB. So we have one of the highest reported road traffic accident. This is mainly because our immigration checkpoint between Singapore and Johor Bahru is the busiest in the world. So we have a lot of young people coming around of Malaysia to go to Singapore to earn the 3 times 5 currency difference. But at the same time, due to the bad traffic, they actually have experience of trauma. Then one of it is rib fractures. So in the year 2022, when I back served in HSAJB, I actually have 41 cases of ESP. But 19 of them personally inserted by me. The other are either I'm supervising or I'm an assistant. So according to this table, you can see that still mainly 70% are less than 65 years old. They are quite young because they are traveling around JB. But some of them are quite elderly with multiple comorbids. Okay, so most of them are unilateral, some are bilateral that I actually inserted bilateral catheters. So I'm using a intermittent bolus strategy rather than an infusion. This is based on my knowledge from diploma in Montpellier. So what I inject is all the patient will receive a catheter at the level of T5. So 20 to 30 mils of ropivacaine 0.37% boluses given, followed by then an intermittent maintenance bolus. We only have 2 machines. So if we have more than 2 patients, that some may need to give clinician manual bolus. So we have 24 hours APS service. So we'll go to give in an interval, regular interval that we are set of either 6 or 8 hour list or even 12-hour list. They effectively reduce the pain. So the tablet, they are being tablet after that. Then most of them have a pain score of more than 4. Actually, all of them have pain score of more than 4, dynamic pain score. If with immediately relief of resting pain score after the ESP insertion, and also reduced to average of 4 after the ESP insertion for the deep chest breathing and also movement of the upper limbs and sitting up. Okay, so overall, we achieve an overall reduction of pain score for both rest and dynamic, and also improvement of forced vital capacity. I actually documented their incentive spirometry from less than 15 mils per kg. After that, they can perform more than 15 mils per kilogram. And mobility capability is better. They can actually sit up more, and also some of them even mobilize to toilet. Clearance of secretion definitely, with weaning from the oxygen therapies. So in conclusion, mortality of rib fracture is very high, especially in 65 years old. So we should consider regional anesthesia technique in our multimodal anesthesia regime. So if the clinical pictures is deteriorate further, so we must provide regional blocks. And at the same time, I think the surgeon might consider rib plating in a frail chest fractures patient. So choice of RA technique, I would say, is very individualized. The ultimate goal should be improving the patient outcomes and optimize the pain efficacy. With that, thank you.